cover the common cerebrovascular disease that's important for neurosurgeon mainly. We'll talk mainly about subarachnoid hemorrhage, okay? The presentation, the causes, complication, and the management. When we talk about cerebrovascular disease, as you know, it's either we are talking about ischemia or hemorrhage. So any vascular pathology, as you know, it presents as hemorrhage or ischemia. The ischemia topic would be covered by the neuromedicine. When we talk about hemorrhage, we have either the spontaneous hemorrhage or the traumatic hemorrhage. Trauma, you have the seminar for head injury with different type of traumatic hemorrhage. What we'll talk today about spontaneous non-traumatic hemorrhage, okay? As we mentioned, the main topic today will be about subarachnoid, special entity of brain hemorrhage, which is subarachnoid hemorrhage. And the name implies subarachnoid hemorrhage in the subarachnoid space. What's subarachnoid space? Is the space between the arachnoid and biamater. You know, we have three covering to the brain. We have the dura mater, arachnoid, and biamater. So between the arachnoid and biamater, we have the subarachnoid space. And this is the space where we have the CSF, the space where the CSF circulate. Okay, and usually this space is filled with CSF. And it includes the interhemispheric fissure, Sylvian fissure, and the space around the brain stem, we call it perimesencephalic cistern, and the small sulci between the brain gyruses, okay? Or these are subarachnoid space. And as you see, the subarachnoid space is continuous space, okay? So, you know, the CSF circulate in the subarachnoid space. So it is continuous. The right and left side are communicates through the interhemispheric and perimesencephalic cistern. So because this is continuous space, bleeding within the subarachnoid space will affect the whole brain. And this is an autopsy showing subarachnoid space affecting the whole brain. And this reflects the poor outcome of patient with subarachnoid space. So this kind of hemorrhage, the subarachnoid hemorrhage, is different from other type of hemorrhage, where the hemorrhage affecting the temporal lobe or the occipital lobe or the frontal lobe. The subarachnoid hemorrhage is affecting the whole brain. And as we mentioned, this reflects the poor outcome of patient with subarachnoid space. So this is special for subarachnoid hemorrhage. So as we mentioned, to summarize, blood within the CSF. The most common cause of subarachnoid hemorrhage is trauma. But today we are not talking about traumatic subarachnoid hemorrhage. We are talking about a spontaneous non-traumatic hemorrhage. And the most common cause of spontaneous non-traumatic subarachnoid hemorrhage is ruptured aneurysm. And up to 80%, other causes AVM, vasculitis, dissection, tumors, hypertension, and about 10% it is unknown. We cannot identify the cause for subarachnoid hemorrhage. The annual rate is about 10 to 28 per 100,000. Okay, so here's some statistics for subarachnoid hemorrhage. The annual rate 10 to 28 per 100,000 per year, or the prevalence. As we mentioned, it's associated with high morbidity and mortality. About 10 to 15% of patients with subarachnoid hemorrhage will die before reaching the hospital. Among the survival, about 1/3 will die within 1 month. 1/3 would have severe outcome, severe deficit, and 1/3 will have good outcome. Most of the aneurysm, about 80 to 90%, will occur within the internal carotid artery territory. Okay, about 10% will occur within the posterior circulation, mainly the basilar artery and its branches. About 1/3 of the patient have multiple aneurysm, more than one aneurysm. This is a bullets of circle. You can see this in the base of the brain. This is the anterior circulation. They include the internal carotid artery, middle cerebral arteries, and ACA, anterior cerebral artery. And this is the posterior circulation. We mentioned most of the aneurysm occur within the anterior circulation, about 80 to 90%. Only 10% occur in the posterior circulation, mainly the basilar and its branches. So this is the basilar, this is the aneurysm. We are talking about cerebral aneurysm. And what's the aneurysm? It's abnormal dilatation of the visual wall, abnormal dilatation, which occurs at a site of bifurcation. Okay, so this dilatation, abnormal dilatation, occur at the site of bifurcation, or sometimes occur at a curving point of an artery, either bifurcation point or curving point of the artery. And it is composed of a sac, okay, and neck. The neck is the site where the sac meets the parent artery. Okay, so we have the sac of the aneurysm and we have the neck of the aneurysm. Okay, within the sac we have the bleb. Okay, the bleb is the weakest point at the tip of the sac, and this is the site of rupture of the aneurysm. Tamam? You know, the visual wall is made of 3 layers. Okay, we have the from inside intima, media, adventitia. Within the aneurysm, we lack these 3 layers. Okay, this is a thin layer of fibrous tissue. Okay. On angiogram, when you have angiogram, this is how the aneurysm looks like. It's abnormal dilatation. And we usually name aneurysm based on its location. Okay, this is aneurysm located in the anterior communicating artery, so we call it anterior communicating artery aneurysm. If it is located in the middle cerebral artery, we call it middle cerebral artery aneurysm. If it affects the carotid, we call it carotid artery aneurysm. So we name it based on the affected vessel. So when we talk about aneurysm, the incidence, about 5% of the population have aneurysm. The rupture rate is about 6 to 12 per 100,000 per year. Rupture to unrupture is 5 to 3. The peak age in the 5th and 6th decade, more common in female. And the majority, about 1/3 of the rupture occurred during sleep. It's very important to know about half of the patient, they have warning symptoms before the rupture. Okay, we call it sentinel headache. Those patients will have a kind of headache, severe headache, before the aneurysm rupture. And we believe that this headache is due to expansion of the aneurysm or due to microhemorrhage or microbleed, or sometimes as oozing from the sac of the aneurysm leak. This leads to severe headache. Okay, and it's very important when a patient have this kind of headache to diagnose him with aneurysm and early stage of subarachnoid hemorrhage before the rupture of the aneurysm, because as we mentioned, when the aneurysm rupture, the outcome is poor. About 15% will die immediately, 1/3 will die within 1 month, 1/3 will have poor outcome or severe disability, and 1/3 will have mild disability. Okay. Subarachnoid hemorrhage can be complicated with intracerebral hemorrhage in about 1/3 of the patient, and can be complicated by intraventricular hemorrhage in about also 1/3. The 1-month mortality rate reach up to 50%. So what's the etiology of the aneurysm? We don't know the exact pathogenesis for the formation or the occurrence of the aneurysm, but we have two main theories. The first one is a congenital theory, which states that the aneurysm developed because we have weakness in the media layer. As we mentioned, we have 3 layers: intima, media, adventitia. And the early theory about the development of the aneurysm state that aneurysm developed because there is a weakness in the media, what we call media defect. However, most of the aneurysm lacks this defect in the media, which make the congenital theory is very questionable. The other theory is acquired theory, which state that aneurysm developed because there is high shear stress at the site of the bifurcation, and this high shear stress will lead to the injury in the intima, and intimal injury will be followed by inflammation of the intima, and this inflammation will extend to the adjacent media at adventitia, leading to fibrosis and sclerosis of the vessel wall, and this lead to weak point in the vessel wall. This weak point will lead to the development of the aneurysm. Okay. We have other special entity for the aneurysm. We call it infectious or mycotic aneurysm, which we usually see in immune-compromised patient. And traumatic, other entities, traumatic or dissecting aneurysm, or these can lead to subarachnoid hemorrhage. Okay. And we have familial aneurysm, okay, which can be seen in patient with collagen disease like Marfan, Ehlers-Danlos syndrome, polycystic kidney disease. We have some risk factor for the development of the aneurysm, like hypertension or diurnal variation in blood pressure, smoking, alcohol consumption, coffee consumption, and the use of oral contraceptive pill, and drug abuse in case of mycotic or infectious aneurysm. How the aneurysm present? As we mentioned, the most common and the most serious presentation is rupture for the aneurysm. And when the aneurysm ruptures, it will present as sudden onset of severe headache, the worst headache in life, associated with nausea, vomiting, decreased level of consciousness, and focal neurological deficit. In addition to meningeal sign, like neck rigidity, Kernicks-Brodzinski sign, and we mentioned about sentinel hemorrhage, which is early stage of subarachnoid hemorrhage and can lead to warning headache. Second presentation is mass effect, especially in large or giant aneurysm, and usually present as compression of adjacent neurostructure, as we see in ICPC aneurysm, leading to compression of the third cranial nerve. The third kind of presentation is incidental finding in patient investigated for other reasons. We find some abnormal vascular lesion. If you have any suspicion for patient presenting with symptom related to aneurysm or subarachnoid hemorrhage, the first thing to do after stabilizing the patient condition, you need to do non-contrast high-resolution brain CT scan. And this is positive, or sensitivity reach up to 98%. We also can detect if there is hydrocephalus, complicating subarachnoid hemorrhage, or ICH or IVH. And we also can measure the amount of blood in the subarachnoid space, what we call the Fisher grade. And this is important for evaluation for vasospasm, as we will see later. Okay. This is a normal CT. This is CT with subarachnoid hemorrhage. You can see blood as hyperdense on the CT, affecting the Selvin fissure, perimesencephalic cister, interhemispheric fissure, perimesencephalic cister, and here also in the fourth ventricle. Here you can see blood intracerebral hemorrhage with subarachnoid hemorrhage, and here we can see IVH. Now, sometimes the clinical presentation is highly suggestive for subarachnoid hemorrhage, but the CT scan is negative. So when you still feel that the patient may have subarachnoid hemorrhage and the CT is normal, you need to do a CSF study. You do lumbar puncture, and you take some CSF and send for analysis. So in a questionable case, you need to do LP. CT scan is not enough. You measure the pressure, you take 3 tube tests. Xanthochromia is yellow CSF, we can see it after 6 hours. MRI is not helpful in acute subarachnoid hemorrhage. This is CSF. Here, this is subarachnoid hemorrhage. You can see blood in the CSF, almost the same amount of blood in subsequent tubes. This is subarachnoid hemorrhage. However, here you can see the amount of blood is decreasing in subsequent tube, and this is traumatic lumbar puncture. Okay. Yellow CSF, we can see it. Xanthochromia after 6 hours due to the hemolysis of the blood in the subarachnoid space. في أسئلة عندكم لهون؟
تمام دكتور. هو عادة الطلاب بيقاطعوك إذا في عندهم أي سؤال.
So, after we diagnose a patient with subarachnoid hemorrhage, either by a CT scan or lumbar puncture, we need to know the cause of subarachnoid hemorrhage by doing angiogram. We do 4-vision angiogram. Okay. And we take different views for the cerebral arteries. Okay.
دكتور عندي سؤال.
تفضل.
بحالة إذا بيكون عندنا الانتراكرينيال بريشر مرتفع، مش إحنا بنفضل ما نعملش اللومبر بانكتشر، ولا إنه بهيك حالة إنه ما فيش عندنا مشكلة؟
سؤال ممتاز. we do the lumbar puncture after the CT scan. Okay. We need to.
Oh.
So initially we do a CT scan. If there is subarachnoid hemorrhage, we don't need to do lumbar puncture. So lumbar puncture only if the clinical manifestation is suggestive for subarachnoid hemorrhage and the CT scan is negative. Okay.
تمام دكتور. Thank you.
So the CT scan should be normal. As you mentioned, if there is bleeding on the CT scan, we cannot do lumbar puncture. And there is no need to do lumbar puncture, actually, because the CT is diagnostic. But in a questionable case, if the clinical presentation is suggestive and the CT is normal, we need to exclude subarachnoid hemorrhage by lumbar puncture. Okay. So angio is to demonstrate the cause of subarachnoid hemorrhage. So we need to do angiogram. We do 4 visual and we study more than one view to identify the cause of subarachnoid hemorrhage. This is with a circle. We can see the common location for aneurysm. The most common is the anterior circulation, the anterior communicating artery, then the middle cerebral artery, and this is the PCOM, posterior communicating artery aneurysm. And the posterior circulation, this is basilar artery, up to 4%. So we mentioned about presentation, diagnosis, and angiogram. Now we have, based on the clinical presentation grading system for subarachnoid hemorrhage, the most commonly used is the Hunt and Hesse grade. And it's from 0 to 5. Grade 1, asymptomatic or mild headache. Grade 2, severe headache and neck rigidity. Grade 3, the patient starts to be lethargic and confused. 4, he's stuporous with neurological deficit, and it's 5, the patient is in deep coma. This classification, as you see, this is based on the clinical manifestation, clinical presentation. So this is clinical grading, and the significance of this grading is the outcome. Okay, so the presentation, the outcome is dependent on the presentation. We can say usually grade 1, 2, and 3 is a good grade associated with good outcome. 4 and 5 is the poor grade associated with poor outcome. And this also grading is important for the management, as we will see later. This is other grading system, which is less commonly used. We don't need to go in details. The other grading is a Fisher grading system, and this grading depends on the amount. This is based on the CT scan, and this depends on the amount of blood on the CT scan. Grade 1, no blood. Grade 2, it is diffuse, less than 1 millimeter thickness. Grade 3, if there is localized clot, more than 1 millimeter thickness. And grade 4, if there is associated ICH or IVH. The important thing about this grade is grade 3, when there is thick clot, more than 1 millimeter thickness. And this grade 3 is associated with high risk for vasospasm. And we'll talk about vasospasm later. Initial management. So if you have a patient with subarachnoid hemorrhage, how will you manage? So you need to admit to ICU, you secure your lines, intubation if the patient Glasgow Coma scale 8 and below, insert external drain if the patient have IVH, control the vital sign, check, okay, head up for the catheter and take output, and you give IV fluid. You need to give some medication, mainly codeine phosphate, as analgesic for the headache, because those patients have severe headache. You need to give analgesic, mainly codeine. You give stool softener, calcium channel blocker, mainly limidobine, and decadron, and prophylactic anticonvulsant. Mainly we give phenytoin. Okay. So the main aim in the initial management. تفضل.
ليش سمعت ستول سوفتنرز؟ ما فهمتش صراحة.
هنحكي هلا the most important issue in the management of those patients is to prevent rebleeding. Okay, so those patients after the initial bleed, they are at higher risk for rebleeding because the aneurysm after it bleed, the bleeding stop, there is another risk for rebleeding and re-rupture of the aneurysm. And this rebleeding and re-rupture is closely related to the blood pressure. Okay, any stress, any strain, okay, can lead to rebleed. And this is why we need to give stool softener to avoid straining of the patient. Because straining can lead to rebleed and re-rupture. Okay?
Okay, thank you.
So we need to control blood pressure before we have, if the aneurysm is not secured, we call it unsecured. It is not treated. Still, there is risk for rebleed or re-rupture. We keep the blood pressure in the low side, normotensive or hypotensive side. Okay. However, after we clip the aneurysm, after we secure the aneurysm, we start to elevate the blood pressure to prevent the vasospasm. Okay. So we give the 3H protocol, which is hypertension, hemodilution, and hypervolemia, okay, to prevent the vasospasm. And we keep the blood pressure on the hypertensive side. So as we mentioned, again, we repeat that our main concern in the initial hours after subarachnoid hemorrhage is to avoid and prevent rebleeding. Okay, and those patients are high risk for rebleed, and rebleeding sometimes equal to death in those patients. Those patients already they have high mortality rate. So if they develop another bleed in the initial hours after subarachnoid or in the first 3 days, this will lead to high mortality reaching up to 70 to 80%. The risk of rebleed is highest in the first day, up to 4%, then it is 1.5% per day. So in the first 2 weeks, above mortality rate up to 70, 80% for rebleeding. Within 2 weeks, up to 20% risk for rebleed. About 50% will rebleed within 6 months. Okay. So we need to avoid rebleeding, and as we mentioned, first thing to avoid rebleeding is to control blood pressure, avoid straining, okay, after subarachnoid hemorrhage. That's why we give good analgesic, we give codeine to avoid straining, we give stool softener, and we keep the blood pressure in the low side after subarachnoid hemorrhage to avoid rebleeding. The second complication of subarachnoid hemorrhage is vasospasm. What's vasospasm? Sometimes we call it delayed ischemic neurological deficit. Okay, why it's delayed? Because usually it occurs after day 3. So it never occurs in the first few days. So it starts on day 3 They peak at day 7 and usually vanish by 2 weeks. Okay. So in vasospasm, okay, it is vasoconstriction, okay, vasoconstriction of the affected vessel, okay, after subarachnoid hemorrhage. The mortality rate for vasospasm 7%, morbidity is 7%, and as we mentioned, start after day 3. And we believe that blood clot after hemolysis can lead to release of some spasmogenic substance. Okay. And as we mentioned, grade 3 Fisher grade associated with high risk for vasospasm. We have 2 types of vasospasm. The clinical vasospasm, about 20 to 30%, when the patient starts to show symptoms of vasospasm. Okay. And we have radiological vasospasm, about 70%, and we can see arterial narrowing or vasoconstriction without clinical symptoms. We call it radiological vasospasm. This is early angio, and this is after 1 week. We can see narrowing of the ACA and MCA and its branches due to vasospasm. And as we mentioned, vasospasm start after day 3, and this is early on angio after subarachnoid. There is normal vessel, and after 7 days, we can see the narrowing in the cerebral vessel, and this narrowing can be severe enough to cause infarction. Okay, but as we mentioned, this usually starts after day 3, and the peak time day 7. Okay. So believe that the hemolysis of the blood in the subarachnoid space can release some vasoactive substance in the CSF, and this can lead to narrowing and vasoconstriction. These substances like iron or adrenaline and deoxyhemoglobin and thromboxane A2 and some free radicals. How to manage vasospasm? We start with prevention, the triple H therapy, as we mentioned, hypertension, hemodilution, hypervolemia. And as we mentioned, this we started after day 3 because hypertension, if we started early, can lead to rebleeding. So early on after subarachnoid hemorrhage, I need to prevent rebleeding by keeping the blood pressure on the low side. Okay. After I secure the aneurysm by clipping or by calling, as we'll see later, I started triple H therapy. Also, nimodipine as vasodilator, calcium channel blocker as prevention for vasospasm, and dexamethasone. For the treatment, if we have already, we can see clinical vasospasm, some patient, we can do balloon angioplasty. We insert a balloon and we dilate the constricted segment of the cerebral vessel, or sometimes we inject intraarterial babavarine or nimodipine. So we start with the treatment of the aneurysm by surgical clipping. The main aim of surgery is to insert clip at the neck to avoid blood from entering the sac of the aneurysm and to prevent bleeding or rebleeding from the sac of the aneurysm. We have different shape of aneurysm. We can use different size and shape of the clips to prevent blood from going to the aneurysm. Okay. And this is the classical treatment, the surgical clipping. Okay, this is the classical associated with high success rate. Okay, mortality usually less than 5%. Okay. So to summarize, after subarachnoid hemorrhage, we try to keep early on the blood pressure on the low side to prevent rebleeding. Then I need to do securing of the aneurysm by clip. I insert the clip as soon as possible whenever the patient condition allowed to prevent rebleeding. After I secure the aneurysm, I start the management to prevent vasospasm, mainly triple H therapy, which is hypertension, hemodilution, and hypervolemia. Okay. The other management line is coiling by interventional radiologist. The coiling using different type of coil, we insert a microcatheter to the sac of the aneurysm, and we start to deploy coils. Within the sac of the aneurysm, there is different size and shapes of the coil, and this coil will end up forming a clot within the sac of the aneurysm to prevent rebleeding. This is successful about 90-95% of cases, but there is a problem of recanalization. Okay, because sometimes we have coil compaction or impaction and recanalization of the aneurysm, and this can lead to subarachnoid hemorrhage and a risk for rebleeding. Okay, so in the long term, surgical clipping have better result than coiling. Okay. So when should I do the coiling? When should I do the clipping? This is a controversial issue, but we have some guidelines. When you have posterior circulation, I prefer to do coiling because of the complication of surgery. If we have wide neck aneurysm, we prefer to do clipping. If there is multiple aneurysm, prefer to do coiling. And if the patient have high Huntington's grade, as we mentioned, grade 4 and 5, high grade, we prefer to do coiling. Timing of surgery, as we mentioned, prefer to do early surgery. Okay, early surgery because we need to prevent rebleeding or re-rupture of the aneurysm, which usually occur mainly within the first 3 days. Okay, so prefer doing early surgery. في أسئلة عندكم؟
دكتور الكويلينج كيف التكنيك تبعتهم؟
It is like any catheterization, like the cardiac cath, but we go to the cerebral vessel. We insert a microcatheter through the femoral artery. Okay?
Okay.
So it is done like any angiogram, but this is interventional angio. The patient is under GA. We insert a catheter from the femoral artery on the right side. We go to the cerebral arteries. To the affected vessel, we insert a microcatheter, and through this microcatheter, we insert the coil. We have different, after we insert the coil, في details كتير مش مطلوب منكم. Okay. We need to do detachment. Okay. يعني الكويل بكون واصل هون بمايكروكاثيتر. Okay. When we are sure that the coil is in its place and its configuration is good, we need to detach it from the main catheter. Okay. And there is different method of detachment. Okay. احنا إذا ما عندكم أسئلة خلصنا هيك for subarachnoid hemorrhage.
ما راح ناخذ الجاينت انيوريزم دكتور؟
احنا بنحكي عن first topic خلصنا.
نعم.
Okay. We mentioned about the early we prefer to do early surgery. Okay. Those patients need to be followed up on a regular basis, the outpatient clinic. And it's important for screening for first degree sibling. Okay, it's important because as we mentioned, about one third of the aneurysm are familial. Okay, so prefer to do screening of first degree sibling. Giant aneurysm is aneurysm more than 2.5 centimeter. Okay, so based on the size, less than 1 centimeter is small, 1 to 2.5 centimeters large, more than 2.5 is giant aneurysm. It's the same pathogenesis. It's less than 5% of all aneurysm are giant, and 1/3 present with the bleeding. Okay, and we have about 1/3 will present with seizure or mass effect and transient ischemic attacks, and 1/3 are asymptomatic. Okay, because partially these giant aneurysms are thrombosed or calcified, angiogram many times underestimate the size. So CT and MRI is more informative concerning the size of the aneurysm. Okay. And the treatment options are the same for aneurysm, which is surgical clipping or coiling, but here we prefer to do surgery because we need to remove the mass effect of the aneurysm because these are large aneurysms. You can see this giant aneurysm of the middle cerebral artery. On the CT scan, you see this mass, rounded lesion, sometimes multilobulated, partially thrombosed, partially calcified. Okay, and these can be a source of thromboemboli causing brain ischemia. Okay, and for treatment, as we mentioned, we prefer to do surgery to remove the mass effect of the giant aneurysm. Okay. Also, if we need to insert coil, we need large size of coils. Okay, to occlude this aneurysm. Okay, other causes of subarachnoid hemorrhage is vascular malformation, mainly the AVM. Talk a little bit about AVM. These are different types of vascular malformation: cavernous angiomas, venous angioma, capillary telangiectasias. For AVM, this is a collection of blood vessels. As you know, normally we have the main arteries, it drain into capillary network, and this capillary network, it drain to a venous blood. In case of AVM, we don't have the normal capillary network. Okay, we have abnormal vessels. So the arteries will end into abnormal vessels. We call it the nidus of the AVM, and this nidus will drain into venous system. Okay, normal veins, we call it draining veins. The arteries, we call it feeding artery. So feeding artery will end into the nidus of the AVM, and this nidus of the AVM will drain into the draining vein. This is a congenital lesion. Presentation is bleeding up to 50%, and mostly the bleeding intracerebral hemorrhage. Okay, may also present with seizure and mass effect. Sometime in pediatric age can present with heart failure. Okay, due to high shift of blood, high volume of blood shifted from the arteria to the venous side. And about 1/3 of the AVM, they have aneurysm. Here we can see the arteries, the feeding arteries. This is the nidus, okay, abnormal visit. And these are the site for rupture and bleed, the nidus. And this nidus will drain into the draining vein. This is how it looks in specimen. On the CT scan, it looks as flickers of calcification or associated with hemorrhage. MRI, we can see the flow void on T1 and T2. This flow void of the feeding arteries and draining vein, sometimes associated with some ischemic changes due to blood shift from the arterial to the venous side. Angiogram, as we mentioned, we can see the feeders, the nidus, and the draining vein. CT scan, this is patient with ICH. And when we do the angio, we can see the nidus and the draining vein, okay, with the feeding artery. Based on the size of the AVM, of the nidus mainly, and the location of the nidus, and the venous drainage pattern, okay, we have the Spitzer and Martin grading system for AVM, and this grade the AVM from grade 0, from grade 1 to grade 5, okay? So, and this is important for the management. If the nidus is small, less than 3 centimeter, we give it 1. If it is from 3 to 6, we give it 2. Large, more than 6, we give it 3 points. Its location, if it is located in the eloquent area, like the motor area, the speech area, we call it eloquent area, we give it 1. If it is non-eloquent, we give it 0. If the draining is superficial, we give it 0. If it is deep draining system, we give it 1. Okay. How we treat, it is multidisciplinary approach. We usually, for grade 1 and 2 and 3, we prefer to do excision, surgical excision. If it is a small and non-eloquent area with superficial draining vein, we prefer to do surgery, excision. Okay. Many times we need to do adjunctive therapy like conventional radiotherapy or embolization. Okay. As we mentioned, surgery indicated for grade 1, 2, and 3. Otherwise, we need to do adjunctive therapy with conventional radiotherapy or embolization. اوكي احنا خلصنا هيك. اذا عندكم اسئله.
يعطيك العافيه.
فيك بس والله عامر تسجل لي مين ما دخل، سلمني إياه الأسبوع القادم.
ان شاء الله.
حطه عند منن الطابق السابع،
عندنا.
لأن أنا مش شايف داخل كم واحد عندكم داخلين. 25.
لا لا لا،
واحد، اثنين،
28 اللي فايتين.
27 عندي.
طيب ولا يهمك دكتور، هاي نزلت انا القائمة وببعث لك الاسماء.
عندي 27 نازلين بس. تمام.
تمام.
يعطيكم العافية.
يعطيك
ما في
العافية
أسئلة.
حكيم.
يلا.
شكرا جزيلا.
شكرا دكتور.
مع السلامة.